Welcome back to our clinic at Harley Academy. I'm Dr. Tristan Mehta, and today our first patient is Lara. Welcome, Lara.
Hey.
Hi. Thanks for coming in today. In your own words, can you tell us a bit about yourself and what potentially you're after?
Sure. I'm 38. I'm from London, born and raised here, and I think I came in just to fix my face.
There's no fix. There's absolutely no fixing required. As you can see, Lara's very beautiful. She's got beautiful skin. And let's have a look at these teeth. So look at those teeth. Incredible baseline to work from aesthetically. Also really interesting ethnic mix. So you're half
Palestinian, I was on Syrian.
Half Syrian. So you've got these really interesting features as well. So clearly we're here just to really just enhance the existing beauty that's already there. And when I look through the face systematically, this can be the kind of patient that we do see in clinic, patients in their mid to late 30s who want to look their best and express how they feel on the inside. And so when I look through the face systematically, we can already see like some really nice standout features. And the opportunity today isn't any single major treatment, but to think about where we can just add a little bit of enhancement across multiple areas for a really nice impact. So let's go through this systematically. So what are the standout dominant features? Well, we've got very, very good skin radiance, good skin texture. We've got good symmetry and good balance across the thirds, vertically and horizontally. Big eyes, and so big eyes can support big features like big lips, for example. If we wanted to go that way, I'm not suggesting we should. We turn to the side, very dominant and striking lower face with that jawline, looking at this nice wide feminine angle, and very nice balance on profile. Not particularly interested in balancing the nose with the chin, because it's already very much in line. Potentially we could project the lips a little bit more, particularly the upper lip, to be more in line with that on profile. And so given that there's nothing standout, I'll talk you through what I see if we're going to treat things systematically, and as an opportunity to show you our injection techniques, how we can really polish things, I would say. So look, in the upper face forehead, we've got a tiny bit here of flattening, and so we can create more convexity in the forehead, which will be a very feminine beautifying treatment. We have some volume loss in the temples. This starts in our 30s when we start to lose deep fat volume. And so we can inject in the temples, which will give a little bit of support to the tail of the brow. We should expect the brow to lift a little bit like this. So that would be an upper face treatment with filler. Okay, I'm not talking about Botox, I'm talking about filler. We've got these very nice cheekbones, but we notice that in the anterior aspect, we get a little bit of flattening. That's because we lose that deep volume in the suborbicularis oculi fat. So we can create some volume at cheek apex, which I think will be very effective in creating a beautification treatment and also reducing a little shadow back here. Lara mentioned that she has felt like she looks a little bit gaunt, and so a bit of volume back here to without reducing this lovely definition on the cheekbone will be very effective at addressing that. And then the final thing for me is the nose and the lips. So a few things with the nose. So first of all, if you give us a really big smile, we notice that the tip of the nose droops down a touch, relax, and smile again. And relax. Biggest smile you can give me. Okay, good. And relax. And the nostrils flare a little bit. And so Lara's mentioned that's a concern, and we can use some toxin to reduce that movement. I can also use some filler just to create a really beautiful straight nose dorsum. So that's what we could do there. And then with the lips, like I said at the start, a little bit of projection, particularly in the upper lip, will be a really nice way to balance that. So all in all, obviously Lara doesn't need any treatment whatsoever. No one needs any treatments, but a really great opportunity to showcase some injection techniques and hopefully a really beautiful before and after as well. So should we get to it?
Yes.
Okay, let's get started. Sorry to interrupt this video. Hi, I'm Dr. Tristan Mehta, founder and CEO of Harley Academy, and I'm the one doing the injection that you're watching right now. I just want to take a moment to talk about our injectables diploma. So Harley Academy is a higher education college for aesthetic medicine based out of the centre of London, UK. And over 3,000 medical professionals have gone through our academic programs to achieve a postgraduate diploma in aesthetics, they will get a title after their name, PG Dip Aesthetics. If you want to learn more about our programs, how you can gain your qualification and learn how to inject in a really structured, systematic and evidence-based way, then click on the details below and our team will be happy to have a conversation with you. Right, that's enough from me. Let's get back to the video. But if you are enjoying this and you want to see more content like this, please subscribe and click like. All right, so let's take a look at Lara and mark on our treatment plan today. So the first thing I mentioned is the forehead, and I'm going to do that when Lara's lying back so I can mark on the exact area that I'd like to treat. In addition, we've got the temporal crest here, and this gives me the zone of the temporal fossa that I want to treat today. Because of the area, the relatively large area that I want to treat, this is less suitable for a direct needle injection, and it's more suitable for the interfacial technique or the subcutaneous technique. In this situation, I want to create some support to the periorbital area as well as restore the volume, so the interfacial technique is the best option for this case. Continuing with the cheekbone, I'm marking the underside of the zygomatic arch, which I always do in my patients, and this shows me exactly the direction of the patient's cheekbone. She has these beautiful feminine cheekbones already, and so I don't think any additional enhancement to the cheekbones will be of much additional benefit. But let's mark on the projected prominent apex of the cheek. If I find the midpoint between the orbital lateral bone and draw a vertical line down, this will generally intersect with where I want this apex to be. And if the patient just looks towards me, I can see in my mind's eye just this little area where I'd really like to see some nice projection, a really nice cheek apex. We would get this really beautifying result. And we can also mark on a secondary area of volume, which is slightly less projected, but helps to continue from the cheek apex down towards the lateral zygomatic arch. This injection here is technically treating the suborbicularis oculi fat, or the SUF. But let's talk about the sequence in turn. We're going to start off with the forehead, then we're going to treat the temples, then we're going to treat the apex of the cheek, and then we're going to move into the under eye itself. The final thing is, with the patient lying flat or lying backwards, I like to scan the patient's head from above, and this just gives it the best view of where we want to treat. And I can see here that the forehead is really nice and projected above this line. And as always, there is some projection at the brow as well. So between those two dotted lines is my treatment band. And you'll notice that it's this typical pattern in most patients that you see for forehead filler. I'm going to access this from the side with a cannula, but if they can't quite reach the middle section of this band, then I can always make an entry point from the top central part of the forehead and treat downwards. I'm also going to start injecting with some lidocaine first. So I use 1% or 2% lidocaine, and it has two major benefits. The first is that it makes this quite scratchy treatment a lot more comfortable for the patient. But the second benefit is actually the lidocaine lifts the muscle away from the periosteum. And this plane is usually closed physiologically. But if we inject lidocaine, we can lift the muscle away from the bone, and it makes our injections much more fluid in this area.
And this is just plain lidocaine, no adrenaline or anything in there as well. And the adrenaline can help reduce some of the bleeding, but it also makes the skin look quite pale because of the vasoconstrictive effect, which in the forehead particularly, if we do have any vascular adverse event or vascular compromise, we want to be able to see that early and sensitively. So
Absolutely.
plain lidocaine, better up again.
And we are very conscious here that the forehead is one of our higher risk zones. And so we have a good conversation with our patient around which zones are considered high risk and relatively low risk. And should we talk about the reason why the forehead is a higher risk zone?
So the vessels, for the most part, we know that the vessels, particularly branches of the supraorbital and supratrochlear arteries, are deep for that initial 2 centimeters above the orbital rim, and then come superficially. So for the most part, as long as we're deep and we're above 2 centimeters from the orbital rim, we're in a safe-ish zone, but they are by no means predictable. So regardless of where we're treating, the risk is somewhat high. And those vessels communicate with the internal course of circulation, which means the risk isn't just to the skin, but also the central retinal artery and the back of the eye.
So we've got these difficult potential anastomoses in a zone that also has a very thin injection plane. And I'll come on to what a thin injection plane means for vascular risk a little later in this video. The entry point that I've made here is down onto bone because the intention here is the cannula can slip behind muscle. It's gliding in the supraperiosteal plane. That's the injection plane that we want to be in when we're injecting the forehead. The purpose here is to create this rounded convexity where we start to see a little bit of flattening in the forehead. That can happen with aging. It can also happen genetically. This convexity is correlated with youthfulness. It's correlated with femininity. And I think in this case would be a really nice enhancement for Lara. So I'm working my way with a fanning motion with gentle continuous pressure on the plunger. And you'll notice that I don't tend to pop superficially as we move towards the midline in this patient, and therefore I'm happy that I won't need to make a central injection point. Sometimes because of the curvature of the forehead, the cannula will inevitably move into the superficial planes more centrally, and that will require a separate entry point, but not in this case.
I think actually pain-wise, with the cannula, it's never too bad. It's more the sensation of it, and you get some people who just don't like that feeling of it. But on the whole, if you're doing them gently and you're using anaesthetic where appropriate, then they should be mostly pain-free. And often, if you are getting lots of pain, that's a sign that something isn't quite right. And to mitigate that vascular risk further, we're using a 22 gauge cannula there as well. There are some areas where we can get away with a 25 gauge cannula, and we get more for comfort, like the under eye area and in the lips. But otherwise, everywhere else, and particularly the upper face, forehead and temples, definitely a 22 gauge cannula.
So I've ended up using a whole 1 mil of filler in this half of the forehead, and I'm using a relatively low G' filler here. I'm using Miley Define, and the reason I'm happy to use a low G' filler here is because if we use quite a stiff filler, we can create these little tracks of gel under the skin, whereas the forehead looks best when there's this even diffuse deposition of filler, but it often means you need a larger volume. So up to 2 mils of a relatively soft product is a really good option here for both longevity and also for getting the best optimal results.
I suppose the other thing we're looking for in terms of filler properties here is something that's cohesive as well, something that wants to stick to itself and is less likely to move about and spread.
So I mentioned earlier about thin tissue planes, and this is a really important concept. If you look on ultrasound at the different zones of the face, you'll be surprised at the difference in depths of the different parts of the face. If you look at the midface or the temples, for example, they are deep cavernous structures, whereas if you look at something like the nose or the forehead, you'll see a very, very thin tissue plane and then bone. And so mathematically, if there's going to be a vessel somewhere between skin and bone, if your plane is only this big, then statistically the risk of being inside a vessel is higher, and that's why these zones, it's another reason why these zones would be considered high risk. So are we still at 0 pain?
Sure.
The forehead we'd say is a treatment which we'd say is development stage 3 under the GEM framework. So it's not suitable for injectors at the start of their journey. It's not something that we would recommend doing until you've done at least 2,000 filler injections. And it's not just about the technical proficiency, it's also the experience you get along the way after treating 2,000 patients with fillers, understanding what complications look like and having enough experience to truly appreciate how patients can recover, what to recognize as these risks, and how that evolves over time. Often the technical aspects of what we teach are not the hard part of injecting. It's more the processes that we have embedded in your brain after doing this over thousands and thousands of injections.
I think it would also be reasonable if this is a treatment you decided you didn't want to do because of the risk profile. That's also completely acceptable. There are people who are very, very experienced who just decide that they don't treat these high-risk areas or refer to someone who does it more frequently. I think one of the things technically challenging here is because, as you said, the planes are so thin, knowing that you're deep, because to the untrained eye, this would look like a superficial injection that you were subcutaneous, because you can see the outlines of the cannula. So much of it is about that feel and knowing that you've gone through the fascia into that subgaleal plane from the outset. Once you're there, you're going to be staying there, but getting there in the first place.
Absolutely. Thanks, Max. Right. So just get into that midline now. That's it. So this is 2 mils of a soft product in the forehead. The product we're using today is Miley from the Sinclair range. That's just a hyaluronic acid gel. Miley and Sinclair also have a biostimulator, Alonze, which is often a good thing to inject alongside their hyaluronic acid range for patients that need a bit more rejuvenation in the treatment phase, regeneration of the dermis. But today we're just using pure hyaluronic acid gels. Now it's really important with foreheads that we don't leave an imprint, and so I'm just using gourds to massage rather than using my direct fingertips. And I'm quite happy here that I've got a nice convexity.
Really nice from the side.
So just sitting forwards now and looking into the camera, turning to the left, you can see this really nice rounded convexity in the forehead. This is generally very supportive to the rest of the treatment plan we have today. But now let's move into the temple. The entry point for the temple is very similar to what we use in the forehead, which is that we find the temporal crest. We're 0.5 centimeter medial, and we're going to use this same zone, but pointing downwards into the temporal fossa. The pilot needle touches down onto bone. We'll leave it there for a few seconds before then slowly moving a 22 gauge cannula into the right depth in the temple. We're going to be treating in layer 4 in the temple, so the layers of the skin, the subcutaneous fat, and in the forehead we have the frontalis muscle overlying the temple. It becomes the superficial temporal fascia. And actually within that layer 3 in the superficial fascia is the superficial temporal artery. That artery is sandwiched between the 2 layers of the superficial temporal fascia. This one theoretically has connections with the internal carotid circulation, and that's why it's a particular danger zone for the temple treatments. You can feel the artery underlying my finger over here, and regardless of that, we're actually injecting deep to the vessel because we're injecting into layer 4, which is the interfascial plane. But it's still important to be aware of where the superficial temporal artery is. As we push through the muscle, we'll feel a little pop. It will move behind the frontalis muscle, and it will move into the temple as the interfascial plane that we're injecting into. This plane is normally collapsed, and so a little bit of anterograde injection whilst we're moving around allows that space to open up. It makes it a much more smooth injection and a much more comfortable injection for our patient as well.
The idea is that if you're underneath the frontalis, which is continuous with the SMAS as well in the midface, by adding volume underneath that, you're providing support and a little bit of tension along the SMAS as well. It's not necessarily going to have a dramatic lifting effect, but certainly a supportive effect on the mid and the lower face as well.
So the reason we inject in this plane in particular is because it doesn't actually have an artery, which would signify the main vascular risk. We do have a vein, which is the sentinel vein. This is moving through the layers of the temple, eventually connecting with the middle temporal vein. We also have another structure, which is the facial nerve, but importantly, we do not have an arterial structure in the interfascial plane. And that gives us confidence when we're injecting. Still here, we're using a 22 gauge cannula, and we're injecting in a very careful way. Now, staying with Miley volume, we're going to be moving to create some projection in the anterior cheek. What we learnt in aesthetic medicine even 1 or 2 years ago is now outdated. Why? Because aesthetics is still a relatively new science, and the research underpinning our work, particularly our understanding of anatomy, has advanced significantly. Hello, I'm Dr. Tristan Mehta, founder and CEO of Harley Academy, and I want to introduce you to GEM, the Global Evidence Matrix. GEM is a dynamic, evidence-based framework that gives injectors a clear, consistent guide for safe, effective treatments, all grounded in science, not in corporate sales pitches. GEM combines clinical research, anatomical knowledge, and injector expertise, and it's always updated with the latest evidence. Think of GEM as your interactive map for facial aesthetics, guiding you through every step from technique to product choice. With GEM, you're not just injecting, you're working at the forefront of medical aesthetics. Join us in setting a new standard for safety and results. When I'm treating the cheek apex like this, we can either enter in order to then follow on and treat the tear trough, or we can enter from a medial entry point to treat the apex and then the zygomatic arch. In this case, because we've got such a nice definition of the zygomatic arch, my entry point is going to be inferolateral to the apex, and then I can treat the soothe in the apex and then move directly to treat the tear trough itself. So let's start off with the cheek's apex.
Just going to make a bit of entry point from this direction.
And then let's go through the layers. So here I am in the subcutaneous plane. I'm going to push through the subcutaneous plane, and there's a dimple. See that dimpling there? That's the SMAS and the orbicularis oculi muscle. And I'm going to push through there. So 1, 2, 3, push. And here I am now in the fat pad directly underneath orbicularis oculi. And here I'm going to gently fan product into my targeted cheek apex that I've drawn on. 0.2 to 0.3 is kind of the volume I'm looking at for this area. And I'm enhancing the definition right on that point where I've identified where I want maximal projection, maximal light reflex. Great, so that's 0.3. And here, what we're going to do is take a little pause. And I'm going to take off the markings and we'll take a look in the camera. And we can see what the temple and the cheek apex like that has achieved. And then we'll move on to the medial cheek. Right, back into the camera for us. Cam, please. Beautiful. So just like that, and perfect. So hopefully what you can see here is we've got a lovely peak to the eyebrow now. This has been elevated. We're starting to see some lifting to the mid face, and I just want you to notice here that the corner of the mouth is lifted as we've got a bit more support, as Max said, underneath the smash. If you give us a big smile, heavily and relax. So we've got all of this support coming backwards. And I hope you can appreciate how effective this beautiful bit of projection is at the apex of the cheek. What I notice now, in terms of my priority, is we have the under eye. And if you just close your eye for me, I like to press here to see if there's any a palpable bag. And in this case, you can see a little bit of bulging. That bulging tells me that there is some intra-orbital fat pseudo herniation downwards, which is giving us this impression of an eye bag. And that means that it's going to be challenging to create a really perfectly smooth transition from the lid to the cheek. However, often with filler under the eye, you can definitely make a big improvement to it. So the first thing I'm going to do is find the bony orbit margin. So this is the kind of origin of our orbicularis retaining ligament, like so. So that's our upper border of any treatment that we'd want to do in the mid face. Then I'm going to look straight at my pencil here, and from the medial of the limbus of the iris down to the prominence of the zygoma, we have where I believe we have the zygomatic cutaneous ligament, kind of in this direction. And between these two ligaments, we have the suborbicularis oculi fat. Now, I've already treated that. I've already created my projection here. But we can see that this SOOF starts to tail off here, and we lose some volume in this area. So this area needs a little bit of volume, but I don't want to use something as projecting as I've already done. So I'm going to use one step down here. And that means that the gel that goes here is a little bit softer, and that will prepare me for the true teardrop injection that I'm going to do. So if you look up this with your eyes. So once I've injected this area with a slightly softer gel, okay, I then have the teardrop itself retreat, which is this tiny channel here. That is my tear trough that I want to treat with the softest possible gel, which will be precise. So I'm going to use Mildly Define in the medial soup, and then Mildly Precise in this teardrop. And that's how I would recommend using these gels. But stronger, softer, and then softest is how we would map the gels to the mechanical and anatomical structures under the eye. So I hope that's clear. If you want to learn more about the particular anatomy under the eye, then we have a lot of specific courses on that within the GEM program. So we can talk a lot more about the very complicated anatomy of the teardrop and the medial cheek in that program. So let's start off. Fine. I've already got my entry points, so I'm very happy that I can reach the teardrop through this access point. I just want you to stay there looking just exactly where you are. So again, I'm going to pop through the orbicularis oculi muscle like this. There. And then I'm just going to start to add a few micro droplets of gel to support the sooth.
It's really clear in Lara when you're going through that, through the orbicularis oculi muscle. In some people, that pop is slightly less defined, so you feel more resistance and some give instead. And you want to be careful in someone who's prone to malar edema in this area. Adding lots of hyaluronic acid, particularly much firmer, high concentration hyaluronic acid, could lead to a bit of swelling. So always check for that before you start these treatments.
Okay, so that was defined, and now I'm going to treat the tear trough itself. So again, same depth, but it will look like I'm moving subcutaneous. And the reason is there's no fat in the tear trough. Just open your eye for me. Perfect. You'll start to see the outline of my cannula here, which is exactly what we expect when we're underneath muscle in the tear trough. Always trying to undercorrect we just want an 80% correction. Okay, we don't want to try and fully treat the hollowing that we see because we anticipate a little bit of swelling.
It's also normal to have a degree of contour between the cheek and the lower eyelid as well. And if you get rid of that and flatten it out completely, it can actually look a little bit strange. It's a bit of a giveaway that someone's had too much fill up under their eye area. The goal is to soften, not necessarily to eliminate completely.
Final thing I'm going to do with this very, very soft gel is I'm just going to improve the palpebromalar groove, which is actually a little compartment above the sooth. And because we're using a really soft gel, I can just try and smooth that transition here from the lid to the cheek in the lateral aspect of the infraorbital region. This treatment is also a stage 2 injection treatment, so this isn't something suitable for total beginners. This entire area is not suitable for total beginners, but somewhere between 1,000 to 2,000 filler injections would be a good time to start looking at this area. The anatomy is probably, I would say, the most complicated of the entire face. Right, let's take a look. Sit forward again. Perfect. Right, so what a brightening I hope you can appreciate. What a change to the under eye. And even though we had that so-called pie bag, we can do a lot to improve the shadow under the eye. And that is all from volumetric replacement. And really important to note that it's tempting to do more, but if we do more, this is where the problems start to happen. We've taken the edge off, we've restored volume in the anatomical places that we're trying to hit. And I'm certain that I've injected in a way that isn't going to create lots of swelling in the future. And that makes me relaxed and comfortable. I know the patient will get a good result. If I overcorrect here, it might look better today, but the patient will be at risk of overfilling. And that's one of the worst things we can do, particularly under the eye. I don't think the periorbital area has particularly high medical risk. I think it has high aesthetic risk. And that's why we have to be very careful when we are injecting this area. Okay, so far so good?
Yeah, all good.
Amazing. Now, we're going to move on to the preauricular area, to turn all the way this way. And I'm going to inject Define. I'm going to use Mighty Define just to create a sheet of hyaluronic acid to try and take some of this hollowing away that would, I think, really suit Lara's lateral face. And this is where we can talk a bit about depth control.
This is such an easy place to slip a little bit too deep. And if you go too deep here, you end up going beyond the fascia and into the parotid gland, which sounds like it could be horribly painful, but it's actually not. So patients won't be able to give you any indication that you're in that layer. You always want to be seeing the outline of the cannula here. And then particularly in someone who's slim, that's quite easy. But in someone who's got a little bit more subcutaneous fat here, it can be a bit more challenging. So if you're not sure about your depth, come back, lift up the tip of your cannula and reassess it. We're using Define here, which is a medium beautifying product. But you could, because of the line of this principle of the line of ligaments and the lateral part of the face behind the bicularis retaining that orbital thickening, behind the zygomatic cutaneous ligament, all of that is immobile, even when the patient is making a quite significant facial expression. So using a slightly firmer product here isn't the problem at all. The main thing to think about is skin thickness and the amount of subcutaneous fat.
All right, thanks, Max. And we can just massage like this. We're using a soft product, so I'm not expecting a huge degree of massage is required, but you can always do a little bit of molding like this. Again, it's really want to see how much this has made a difference. So sit forwards again for us. And usually when we treat along the jawline like that, we can start to see a little bit of lift. So if you look into the camera, I really start to notice now this entire half of the face is lifted, more youthful, more supported. Okay, we're now moving on to our final injections for this sequence, okay? We're going to spend some time with the nose, and then we're going to look at the lips, and then I'll treat this entire other side of the face off camera, and then I'll show you what it looks like once we've treated the whole face.